I am presenting a case of 55-year-old male patient presenting with complaints of pain in right lower abdomen for 2 months, lump in right lower abdomen, since last 1 month. Patient was apparently asymptomatic, since last 2 months, when he developed pain in right lower abdomen which was insidious in onset, dull aching in nature, mild in intensity, initially intermittent, but constant since last 1 month, aggravated by food intake, relieved by analgesic for few hours. There is no radiation or referral of pain. 1 month back, patient felt a lump in right lower abdomen, which was initially around 3 finger breadth in size, but in last 1 month has progressed to 4 fingers. There is mild pain experienced by patient when he presses the lump.
What do you mean by insidious?
Insidious means something harmful is developing inside and person is not aware of.
Can pain be insidious?
No, pain can never be insidious. You cannot have pain inside which is not felt. You either feel pain or don't.
Pain was initially intermittent, but became constant later on. What does it suggest?
Change in character of pain suggests change in pathology. There could be increase in dimension or diseases involving adjoining structures. Patient has history of dysregulated bowel habits with frequent bouts of constipation since last 8 to 10 years. There is history of painless passage of red blood in stools, while defecation, since last 4 to 5 years with 2 to 3 episodes, after every few months. Patient consulted a local doctor, where he was diagnosed as having piles.
Don't say local doctor, say local available physician or doctor.
Patient consulted few doctors for dysregulated bowel habits, but never undergo any major tests. There is no history of black stools, mucus discharge in stools, fever, vomiting, chronic cough, breathlessness on exertion, chest pain, any other pain in abdomen, back pain, significant weight loss, urinary symptoms, no history of loss of appetite, but patient diet has decreased, owing to constant pain.
Why did you take history of black stools?
Passage of black stools could suggest melena.
What is melena?
Melena is passage of black, thick, viscous, foul-smelling stool, as thick as coal tar. It suggests bleeding in upper GI system.
Why lower GI bleeding does not cause melena?
In melena, 2 things occur. One is conversion of hemoglobin to hematine by acid, and second is mixing of altered blood with stools by peristalsis for long time. This churning causes thick black stool with uniform consistency. In lower GI, there is no acid and mixing is not occurring for long period as stool gets evacuated. So lower GI bleeding presents with red-colored stool.
Why have you taken history of chest symptoms?
I have taken history of chest symptoms to rule out tuberculosis or secondary involvement of thorax by lung metastasis. Plus patient is known smoker, so assessing chest fitness is important.
Why urinary symptoms?
Right lower abdomen lump can be lump arising from lower pole of kidney, plus any pathology separate from kidney can involve ureter, as it crosses iliac fossa. Patient belongs to low socioeconomic class. He is an occasional non-vegetarian in diet.
What type of non-vegetarian is he?
He consumes both red meat and white meat.
Why is red meat called so?
Red meat is red in color from inside due to present of high amount of myoglobin. Red meat consumption is more harmful. There is history of moderate alcohol consumption, cigarette smoking. Patient has habit of chewing pan masala with tobacco.
How do you quantify smoking?
By calculating pack years.
How is pack years calculated?
It is calculated by multiplying the number of packs of cigarettes smoked per day by the number of years the person has smoked. For example, 1 pack a year is equal to smoking 1 pack per day for 1 year, or 2 packs per day for half a year, and so on. There is no past history of diabetes mellitus, hypertension, tuberculosis or any other chronic problem, except altered bowel habits.
You take past history of problem which could have affected patient, but now he is free. Diabetes and hypertension, once occurred, become lifelong illness. Once labeled, you cannot be free. You only can control them. So don't say past history. Say, there is no concomitant medical history of diabetes and hypertension. You can say past history of tuberculosis, as tuberculosis can occur and then can get cured by treatment.
There is no history of previous hospitalization or any surgery, no history of any drug allergy or addiction.
Why do you ask for drug allergy?
We asked for drug allergy so that we could avoid them during treatment. No family history of any cancer-related event in first-degree relative. One second-degree relative, his aunt, 15 years older than him, developed breast cancer and has undergone treatment and she is asymptomatic at present.
Who are first-degree relatives?
Parents and siblings are first-degree relative.
Is this incidence in his aunt correlated with our patient's problem?
Less likely, as patients are develop breast cancer at older age group, hence more likely to be no genetic predisposition. On examination, patient was examined in a well-lit room with consent for examination. He is average build, BMI, 26.3, fully conscious, cooperative, well-oriented to time, place and person.
Is BMI normal?
No, he is overweight, but not obese, which is 30 and above. On general examination, mild pallor present, no icterus.
A conventional dictum was to take patient near window where sunlight is coming to check for icterus. Did you do it bedside or near window?
Practice of checking icterus near window was because of incandescent yellow light bulbs, in older days, which could give slight yellow tinge to skin and sclera, so confused with jaundice, hence white light is preferred. For white light, sunlight is good, but in patient's ward there was white LED light, so I examined patient for icterus bedside in white light. No clubbing.
Can we expect clubbing in this case?
No, clubbing usually occurs in chronic long-standing problems. This patient has a very short history. No cyanosis, restricted mouth opening with 2 finger breadth, dentition intact, but rugged edges with black stains all over dentition. Buccal mucosa is pale.
What condition is this?
This is submucous fibrosis.
What is the cause of submucous fibrosis?
Submucous fibrosis is caused by areca nut, also called superi. Jagged edges leads to repeated trauma in buccal mucosa and subsequent fibrosis in mucosa and submucosa. Fibrosis causes paleness of mucosa due to reduced blood supply. Hence, normally pinkish mucosa appears pale white, and due to fibrosis there is reduced mouth opening.
Is this condition precancerous?
Yes, submucous fibrosis has 5% chances of malignancy.
What other problem can occur in this patient with submucous fibrosis?
If patient is taken up for surgery, then there will be difficulty in intubation for general anesthesia. There is no significant lymphadenopathy in cervical, axillary and inguinal area, especially in left supraclavicular fossa.
Why specially left supraclavicular fossa?
Lymph nodes present in left supraclavicular fossa, just medial to internal jugular vein, receives lymph from abdominal viscerus. Hence, any pathology like malignancy in GI organs can reach this node.
What sign is this?
Troisier sign.
Which neck level is this node?
This node is behind sternocleidomastoid muscle, anterior border of posterior triangle. Level 5 is posterior border of sternocleidomastoid. Hence, this node is level 4. On musculoskeletal examination, there is no restriction of motion in any extremities, especially in right hip joint. There is no spine tenderness.
Why specially examining right hip joint?
Any pathology in right iliac fossa can involve muscle of iliopsoas, leading to restriction in thigh movement, like insosubsis. On respiratory system examination, bilateral fine creps in both sides, bilateral vesicular sound heard. In cardiovascular system, blood pressure is 140 by 92 mm of mercury, pulse 83 per minute, normovolumic, normal rhythm. In CNS, higher functions intact, no obvious cranial nerve palsy, no tremors in hand. In local examination, abdomen is flat with no fullness visible, all quadrants moving equally with respiration, no scar mark, no visible veins, no bowel loops visible, genitalia appears normal, no cough impulse in inguinal region. On palpation, my findings of inspection are confirmed, no local raise in temperature, there is mild tenderness on deep palpation in right iliac fossa. There is a well-defined lump present in right iliac fossa extending into right lumbar region. Surface is nodular, margins are irregular, lower margin is reachable, mobile in left to right direction, mildly tender, firm in consistency.
Lower margin of lump is reachable means what?
If lower margin of lump is reachable, then it suggests that lump is not pelvic in origin. On percussion, there is resonant note over lump. There is no shifting dullness or fluid thrill. On auscultation, 3 bowel sounds are heard in 1 minute.
Why is there resonant note over lump?
On percussion, there could be resonant note, due to presence of any ileal loop over the cecal mass. On perectal examination, prolapse internal hemorrhoids are present at 3 o'clock.
Why are you saying internal hemorrhoids, not external?
Internal hemorrhoids are covered by a mucosa, while external hemorrhoids are covered by skin.
What grade of hemorrhoids is this?
Grade 3, as they have to be reduced manually. No growth or ulcer palpable in anorectum. No enlargement of prostate.
What is your provisional diagnosis?
I would like to keep a differential diagnosis of carcinoma cecum, ileocecal tuberculosis, inflammatory bowel disease.
Why have you kept carcinoma as first diagnosis?
Because there is a short history of symptoms, although patient had altered bowel habits but they were present since many years and appeared more due to other problem. Short history goes more in favor of cancer. Both tuberculosis and inflammatory bowel disease will have symptoms for longer duration before such lump is formed.
Why can't it be appendicular lump?
Appendicular lump forms after appendiceal perforation due to attack of acute appendicitis, so patient's symptoms in appendicular lump would start with acute pain in right iliac fossa.
What form of tuberculosis can cause such lump in right iliac fossa?
Hyperplastic tuberculosis of bowel can cause lump in abdomen due to severe thickening of bowel wall.
What are the other ways in which abdominal tuberculosis can present?
Abdominal tuberculosis can present as hyperplastic tuberculosis or ulcerative variety, which may lead to bleeding, mucus discharge, perforation, acidic form, where patient presents with ascites, peritoneal form associated with clumping of bowel and cocoon formation. There could be tubo-ovarian mass.
How will you explain pallor? Patient had few intermittent episodes of hemorrhoidal bleeding.
Pallor is more likely due to cecal disease leading to occult bleeding in stools, exacerbated by hemorrhoidal bleeding.
How will you proceed?
I will first order blood tests, complete blood count, liver function tests, kidney function tests, coagulation profile, hepatitis B and C test, HIV test, serum carcinoembryonic antigen.
Why KFT and LFT?
Kidney function test is required, because I will plan patient for contrast CT scan, for which kidney function should be normal, as IV contrasts dye is nephrotoxic. LFT is done, because patient is known alcoholic, hence, I would like to assess liver function.
Why coagulation profile?
At some point, I will plan my patient for colonoscopy and biopsy, so coagulation profile is done, so that, if deranged, it can be corrected before invasive procedure.
How will you correct coagulation profile if found deranged?
I will give vitamin K injections and transfuse fresh frozen plasma, if needed.
Can serum carcinoembryonic antigen be raised in this patient without malignancy?
Serum CEA can be mildly raised in those patients who smoke.
After blood tests, how will you proceed?
I will assess hemoglobin levels and send blood for cross-match and transfuse PRBC. If hemoglobin is low, then I will go for CT thorax and abdomen, with both intravenous and oral contrast.
Why CT thorax?
To assess lung mets.
Which is the most common site of mets in colon cancer?
Most common site of colonic cancer mets is liver.
Suppose CT abdomen shows thickened cecum with narrowed lumen with few small lymph nodes and mesentery. Rest normal. Would you consider carcinoma or tuberculosis first?
Intestinal hyperplastic tuberculosis usually causes pulled up cecum, where cecum gets lifted due to fibrosis and lies more in lumbar region. Here, if CT shows normal position of cecum, then diagnosis of carcinoma is more likely.
Why not inflammatory bowel disease?
IBD cause thickening of bowel in larger area. It would not cause as thickening of only small area like just cecum.
How will you confirm?
I would go for colonoscopy and biopsy of cecal wall.
Suppose colonoscopy finding is suggestive of cecal growth and biopsy comes out to be adenocarcinoma. Now what?
Since there is no evidence of metastasis, and cecum is mobile, suggesting that it is not involving posterior abdominal wall, so I will go for surgery.
What surgery will you do?
Right hemicolectomy.
How much bowel is removed in right hemicolectomy?
6 centimeters of terminal ileum, cecum, ascending colon, right 1/3 of transverse colon.
What vessels will be ligated?
Iliac colic artery, right colic artery and right branch of middle colic artery.
What will you do after resection?
I will do iliac transverse anastomosis.
Which structure can get injured during right hemicolectomy?
Right ureter and duodenum.
What can be done to facilitate identification of ureter during surgery?
We can place a plastic DJ stent in right ureter, through cystoscopy before surgery. This will enable identification of ureter, as stent could be easily palpated.
After right hemicolectomy, biopsy comes adenocarcinoma. Involvement up to serosa, 0/8 nodes negative. How many nodes must be removed in colon cancer surgery?
At least 12 nodes must be removed.
What will be the further planning?
We will plan for adjuvant chemotherapy, as disease is up to serosa.
What chemo is given?
Folflox or Capiax. They contain capecitabine fluorouracil along with oxaliplatin.
What is duration of adjuvant chemotherapy?
At least 6 months.
Join our YouTube channel to learn surgery in a simple way.